Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansariya University. In this series of 4 lectures, heart diseases are addressed from the pathological points of view. Previous presentation outlined heart failure topic in details. The causes and etiological factors of congenital heart diseases were also addressed. Based on the hemodynamic and clinical consequences, congenital heart disease can be first, malformations causing a left to right shunt, for example, ventricular septal defect. I already talked about it. Other examples are atrial septal defect, patent ductus arteriosus will be discussed here in more details. In addition, this presentation will try to cover malformations cause right to left shunt. This is called the cyanotic congenital heart disease, including tetralogy of Fallot and transposition of a great artery. The malformation causing obstruction will also covered in this presentation, taking coarctation of aorta as an example. At the end of this lecture, I'll try to talk about the ischemic heart disease. So, the atrial septal defect is an abnormal fixed opening in the atrial septum that allows unrestricted blood flow between the atrial chambers. Majority, about 90% of atrial septal defects are so-called ostium secundum defects, in which growth of the septum secundum is insufficient to occlude the second ostium. Other types are ostium primum atrial septal defects, which account about 5%. Sinus venosus, either superior or inferior sinus venosus atrial septal defect, and we have also the coronary sinus defects. This figures shows various types of atrial septal defects, including the primum atrial septal defects, secundum atrial septal defects, which is the most common type, and the superior and inferior sinus venosus defect, and finally the coronary sinus defect. The next slide shows a heart with both an atrial septal defect and a ventricular septal defect, as denoted by yellow arrows. For the morphology, ostium secundum ASDs are typically without other associated cardiac abnormalities. Hemodynamically significant lesions are accompanied by right atrial and ventricular dilation, right ventricular hypertrophy, and dilation of the pulmonary artery, reflecting the effects of a chronically increased volume load. Clinical features. ASDs usually are asymptomatic until adulthood, which are less likely to spontaneously close, and they are the most common defects to be first diagnosed in adults. In addition, ASDs initially causes left to right shunts due to lower pressures in the pulmonary circulation on the right side of the heart. In general, these defects are well tolerated, especially if they are less than 1 centimeter in diameter. Even larger lesions do not usually produce any symptoms in childhood. Over time, however, chronic volume and pressure overloads can cause pulmonary hypertension. Surgical or intravascular ISD closure is thus performed to prevent the development of heart failure, paradoxical embolization, and irreversible pulmonary vascular disease. The next congenital heart disease is patent ductus arteriosus. The ductus arteriosus arises from the left pulmonary artery and joins the aorta just distal to the origin of the left subclavian artery. During intrauterine life, it permits blood to flow from the pulmonary artery to the aorta, bypassing the unoxygenated lungs. Obliteration occurs after birth. The figure shows the common congenital causes of left to right shunts, including atrial septal defect, ventricular septal defect, and patent ductus arteriosus. The arrows indicate the direction of the blood flow. The great majority of patent ductus arteriosus, about 90%, are isolated defects. Clinical features: patent ductus arteriosus are high pressure left to right shunts. Small patent ductus arteriosus generally causes no symptoms, although larger defects eventually can lead to Eisenmenger syndrome with cyanosis and congestive heart failure. High pressure shunts also predispose patients to develop infective endocarditis. Isolated patent ductus arteriosus should be closed as early in life as feasible. Secondly is the malformations associated with right to left shunts. These malformations are distinguished by early cyanosis, so it is called cyanotic congenital heart disease, due to flow of poorly oxygenated blood from the right side of the heart directly into the atrial circulation. The most important conditions are: first, the tetralogy of Fallot; second is the transposition of the great vessels. Clinical consequences of severe systemic cyanosis include clumping of the fingers and toes, and this is called hypertrophic osteoarthropathy, polycythemia, and paradoxical embolization. First is the tetralogy of Fallot. It accounts for about 5% of all congenital cardiac malformations. The four cardinal features are pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and finally overriding of the aorta. The overriding of the aorta is when the aorta is positioned directly over a ventricular septal defect instead of over the left ventricle. The heart is enlarged and become boot-shaped as a consequence of the right ventricular hypertrophy. The clinical features: the hemodynamic consequences are right to left shunting, decreased pulmonary blood flow, and increased aortic volumes. The clinical severity largely depends on the degree of pulmonary outflow obstruction. Thus, if the pulmonary obstruction is mild, the condition resembles an isolated ventricular septal defect because the high left-sided pressure causes only a left to right shunt with no cyanosis. More commonly, more severe degree of pulmonary stenosis causing early cyanosis. The pulmonary outflow stenosis protects the pulmonary vasculature from pressure and volume overloads, so the pulmonary hypertension does not develop and right ventricular failure is rare. Patients develop the typical sequelae of cyanotic heart disease, such as hypertrophic osteoarthropathy, polycythemia with attendant hyperviscosity, and increase the risk of infective endocarditis and systemic embolization. The next example is the transposition of great arteries. The transposition of a great artery is a discordant connection of the ventricles to their vascular outflow, so that the aorta arises from the right ventricle and the pulmonary artery emanates from the left ventricle. As seen in this figure, the transposition of the great vessels with and without ventricular septal defects. The functional outcome is separation of the systemic and pulmonary circulations, a condition incompatible with postnatal life unless a shunt such as a ventricular septal defect, atrial septal defect, or patent ductus arteriosus allows delivery of the oxygenated blood to the aorta. Clinical features: the dominant manifestation is cyanosis. Without surgery, even with stable shunting, most patients with uncorrected transposition of a great artery die within the first months of life, so they should undergo corrective surgery within weeks of birth. Next is the malformations associated with obstructive lesions. Congenital obstruction of blood flow can occur at the level of the heart valves or within a great vessels. Relatively common examples include pulmonary valve stenosis, aortic valve stenosis or atresia, and finally coarctation of the aorta. We will take the coarctation of the aorta as an example. The coarctation of the aorta means narrowing or constriction of the aorta. As you know, the males are affected twice as often as females. Females with Turner syndrome frequently have coarctation. It occurs as a solitary defect, but in more than half of the cases is accompanied by a bicuspid aortic valve. Aortic valve stenosis, ASD, VSD, or mitral regurgitation also can be present. There are two classic forms. First, an infantile preductal coarctation. For the morphology, is characterized by circumferential narrowing of the aortic segment between the left subclavian artery and the ductus arteriosus. The ductus typically is patent and is the main source of unoxygenated blood delivered to the distal aorta. The figure shows the coarctation of the aorta. On the left side, the infantile or preductal forms, and on the right side, without a patent ductus arteriosus, which is the adult or postductal forms. So, for the infantile type or the preductal forms, right side of the heart perfuse the body distal to the narrowed segment. The right ventricle hypertrophied and the pulmonary trunk is dilated to accompany the increased blood flow. Clinical feature of it will be usually presented early in life with congestive heart failure. Selective cyanosis localized to the lower limbs because of the perfusion by poorly oxygenated blood via ductus arteriosus. In addition, femoral pulse is weaker than those of the upper limbs. and without intervention, most affected infants die in the neonatal periods. Next is an adult postductal coarctation. Regarding the adult postductal coarctation, which is seen on the right side of the figure, it is the more common form in which the aorta is sharply constricted by a tissue ridge adjacent to the non-patent ligamentum arteriosum, distal to the obliterated ductus arteriosus. Proximal to the coarctation, the aortic arch and its branch vessels are dilated, and the left ventricle is hypertrophied. Collateral flow through the intercostal and epigastric arteries supply blood to the distal aorta. As seen in this figure, the collateral circulation, in which the blood will pass from the arch of the aorta then to the subclavian artery, internal thoracic artery, anterior intercostal artery, and then to the posterior intercostal artery, and finally to the thoracic aorta. The most common location for the coarctation of the aorta is distal to the left subclavian. Clinical features is asymptomatic and recognized well into adult life. Oxygen contents is normal and selective cyanosis is not seen because blood reaching distal aorta come from collateral. There is upper extremity hypertension paired with weak pulses and relative hypotension in the lower extremities, associated with symptoms of claudication and coldness. Collateral circulation around the coarctation often develops through markedly enlarged intercostal and internal mammary arteries. Expansion of the flow through these vessels can lead to radiologically visible notching of the ribs. This figure shows the chest X-ray finding, which shows the rib notching, and also it shows the figure 3 sign. Figure 3 sign is another radiological sign occur in addition to the rib notching, which appears to the left of the mediastinum and is caused by pre and post stenotic dilatation of the aorta. This figure is also for an patient chest X-ray, and the main finding is the rib notching. Topic will try to be covered in this lecture is the ischemic heart disease. The ischemic heart disease is a broad term including several closely related syndromes caused by myocardial ischemia, an imbalance between cardiac blood supply and the myocardial oxygen and nutritional requirement. The ischemic heart disease in its various forms remains the leading cause of mortality in developed nations. In greater than 90% of cases, ischemic heart disease is a consequence of reduced coronary blood flow secondary to obstructive atherosclerotic vascular disease. In the remaining cases, ischemia may be the result of increased demand, diminished blood volume, for example, hypotension or shock, diminished oxygenation, for example, pneumonia or congestive heart failure, or diminished oxygen carrying capacity, for example, anemia or carbon monoxide poisoning. The main risk factors of ischemic heart disease are first, the age more than 40 years, sex in which the male are more than female, atheroma. Fourth is the hyperlipidemia, either congenital or acquired. Hypertension and diabetes mellitus also has a role in the ischemic heart disease. Smoking, the obesity and diet, oral contraceptive pills, and finally the psychological and emotional factors and the family history. The clinical presentation may include one or more of the following cardiac syndromes. First, we have the angina pectoris. Ischemia induces pain but is insufficient to cause myocyte death. Angina can be stable, occurring predictably at certain levels of exertion, can be caused by vessel spasm, this is called transmetal angina, or can be unstable, occurring with progressively less exertion or even at rest. Secondly, we have the myocardial infarction, occurs when the severity or duration of ischemia is sufficient to cause cardiomyocyte death. Thirdly, we have the chronic ischemic heart disease with congestive heart failure. Progressive cardiac decompensation occurs after acute myocardial infarction or secondary to accumulated small ischemic insults. Finally, precipitates mechanical pump failure. The last entity is called the sudden cardiac death. Occurs as a consequence of tissue damage from myocardial infarction, but most commonly results from a lethal arrhythmia without myocyte necrosis. The term acute coronary syndrome is applied to any of the three catastrophic manifestations of ischemic heart disease, including unstable angina, myocardial infarction, and sudden cardiac death. Regarding the pathogenesis of ischemic heart disease, is a consequence of inadequate coronary perfusion relative to myocardial demands, usually as a consequence of a pre-existing fixed atherosclerotic occlusion of the coronary arteries and new superimposed thrombosis and or vasospasm. Fixed obstructions that occlude less than 70% of a coronary vessel lumen typically are asymptomatic, whereas lesions that occlude greater than 70% of vessel lumen, resulting in so-called critical stenosis. Certain levels of exertion predictably cause chest pain, and this is called the stable angina. A fixed stenosis that occlude greater than 90% of vascular lumen can lead to inadequate coronary blood flow with symptoms even at rest. This is one of the forms of unstable angina. If an atherosclerotic lesion progressively occludes a coronary artery at a sufficiently slow rate over years, other coronary vessels may undergo remodeling and provide compensatory blood flow to the areas at risk. The acute plaque changes. The onset of myocardial ischemia depends not only on the extent and severity of fixed atherosclerotic disease, but also on dynamic changes in coronary plaque morphology. This is the diagram of sequential progression of coronary artery lesions leading to various acute coronary syndromes. The initiating events is typically a sudden disruption ranging from erosion to rupture of a partially occlusive plug, and this exposes highly thrombogenic constituents or underlying subendothelial basement membrane and lead to rapid thrombosis. In addition, hemorrhage into the core of the plugs can expand plug volume, thereby acutely exacerbating the degree of luminal occlusion. The first clinical presentation is the angina pectoris, is an intermittent chest pain caused by transient reversible myocardial ischemia. The following three variants are recognized. First, the typical stable angina. It is an episodic chest pain and it is a crushing or squeezing substernal sensation that is radiated to the left arm or left jaw, and this is called referred pain and associated with exertion or some other increased demands, for example tachycardia, and relieved by rest or by drugs such as nitroglyceride. Secondly, we have the presmetal or variant angina, occurs at rest and is caused by coronary artery spasm. Although such spasms typically occur on or near existing atherosclerotic plugs, a completely normal vessel can be affected. It responds to vasodilators. It is associated with marked ST elevation with increased R waves amplitude that presents during anginal attack. Thirdly, we have the unstable angina, which is also called crescendo angina. It's characterized by increased frequency of pain, precipitated by progressively less exertion or even at rest, more intense and lasts longer than stable angina pectoris. It is associated with acute plug changes with superimposed partial thrombus, distal embolization of the thrombus, and or vasospasm. It can be harbinger of the myocardial infarction. The second clinical presentation of ischemic heart disease is the myocardial infarction. It commonly referred to as heart attack. It is necrosis of the heart muscle resulting from ischemia. For the pathogenesis of myocardial infarction, most myocardial infarctions are caused by acute thrombosis within coronary arteries, disruption or erosion of pre-existing atherosclerotic plug serves as the nodes for the thrombus generation, vascular occlusion, and subsequent infarction of the perfused myocardium. In 10% of myocardial infarctions, however, transmural infarction are mostly attributed to coronary artery vasospasm or to embolization from mural thrombi, for example, in atrial fibrillation or from valve vegetations. Myocardial infarctions begins within 20 to 30 minutes of coronary artery occlusion in the subendocardial region because it is the least area to receive blood from coronaries, then extended peripherally reaching full 3 to 6 hours. During this period, lysis of the thrombus by thrombolytic agents may limit the size of infarct. The location, size, and morphological features of acute myocardial infarction depends on multiple factors. First, we have the site of occlusion. When the occlusion of the left anterior descending coronary arteries about 40 to 50%, this leads to infarction of the anterior and apical areas of the left ventricle and adjacent interventricular septum. The right coronary artery occlusion leads to posterior and basal portion of the left ventricle. Secondly, we have the underlying anatomy of the coronary circulation. Third, the duration of the occlusion, the size of the vascular bed supplied by the obstructed vessels, the metabolic demands of the myocardium, affected, for example, by the blood pressure and heart rate. And finally, we have the extent of coronary supply. The epicardial vessels are interconnected by numerous intercoronary anastomoses, and this is called the collateral circulation, which are normally closed, but gradually narrowing of one artery allows blood to flow from high to low pressure areas through the collateral channels. In this manner, gradual collateral dilatation can provide adequate perfusion to areas of the myocardium. Based on the size of the involved vessels and the degree of collateral circulation, myocardial infarction may take one of the following patterns. First is the transmural infarction, involve the full thickness of the ventricle and are caused by epicardial vessel occlusion through a combination of chronic atherosclerosis and acute thrombosis, yield on ECG changes such as the ST segment elevation and can have negative Q waves with loss of the R wave amplitude. And this is called the ST segment elevation myocardial infarctions. We have also the subendocardial infarction are limited to the inner third of the myocardium, typically do not exhibit ST segment elevation or Q waves on the ECG, and this is the non-ST segment elevated myocardial infarctions, although they can have ST segment depression or T wave abnormalities. This figure shows the dependence of myocardial infarction on the location and nature of the diminished perfusion. On the left, pattern of transmural infarction result from major coronary artery occlusion, including the left anterior descending branch, left circumflex branch, and the posterior descending branch of the right coronary artery. On the right, the pattern of infarction results from partial or transient occlusion, the top one, and lead to the regional subendocardial infarct. Global hypotension superimposed on fixed three-vessel disease in the middle lead to circumferential subendocardial infarct. And we have also the occlusion of small intramyocardial vessels at the bottom lead to the microinfarcts. The next figure shows the pattern of topographic distribution of myocardial infarction in the heart, including the regional transmural infarction, regional subendocardial infarction, circumferential subendocardial infarction, and the diffuse multifocal infarction. The regional transmural infarction with the ECG changes showing the ST segment elevation, which cannot be seen in the regional subendocardial infarction. For the morphology of myocardial infarction, it depends on the age of the injury. Areas of the damage progress through a sequence of morphologic changes from coagulative necrosis to acute and then chronic inflammation to fibrosis. It proceeds invariably to scar formation without any significant regeneration. Evolution of morphologic changes in myocardial infarction is as follows. Up to half an hour, reversible injury is noticed during this period, whereas irreversible injury occurs later on. Non-gross or microscopic changes recognized. From half an hour to 4 hours, non-gross features are found, microscopic finding usually none, and variable waviness of fibers at border. This figure of normal myocardium, microscopic normal cardiac muscle in longitudinal section shows a syncytium of myocardial fibers, cardiac myocyte with centrally located nuclei. From 4 to 12 hours, grossly, occasionally dark, mottling, irregular marks, spots or patches of different shades or colors. Microscopically, beginning of the coagulation, necrosis, edema, and hemorrhage. Later on, from 12 to 24 hours, grossly, there will be appearance of the dark mottling. Microscopically, ongoing coagulation, necrosis, pycnosis of nuclei, hypereosinophilic appearance of myocytes, marginal contraction, band necrosis, and also the beginning of neutrophilic infiltrate. This figure shows how the dark mottling looks like. From the first to the third days, grossly mottling with yellow tan infarct center will appear. On microscopic feature, coagulation necrosis with loss of nuclei ancestration, in addition to the interstitial infiltrate of neutrophils. From the third to the 7 days, grossly hyperemic borders along with the central yellow tan softening will appear. In microscopic feature, there will be the beginning of disintegration of dead myofibers with dying neutrophils, along with early phagocytosis of dead cells by macrophages at infarct border. This figure shows the yellow tan infarct with surrounding hyperemic border. Later on, from the 7 to 10 days, grossly there will be maximal yellow tan and soft with the depressed red tan margins. Microscopically, well-developed phagocytosis of dead cells, early formation of fibrovascular granulation tissue at margins. From day 10 to 14, grossly there will be red grade depressed infarct borders and microscopically well-established granulation tissue with the new blood vessels and collagen deposition. From the 2nd to 8 weeks, grossly there will be gray-white scar progressive from the border toward core of infarct. Microscopically, increased collagen deposition with decreased cellularity. Greater than 2 months, there will be scarring complete and microscopic feature will be established as dense collagenous scar. This is a summary of pathological changes after myocardial infarction. Grossly, less than 4 hours, there is none changes appear. From the 4 to 24 hours, there will be dark mottling. From the first to the third day, there will be infarct, center and yellow in color. from the 3rd to 7 days, hyperemia at borders from the 1 to 2 weeks, red, gray, and depressed borders from 2 to 8 weeks. The gray-white granulation tissue will start to appear, and there will be complete scars when there is greater than 2 months in age. This figure shows the microscopic features of myocardial infarction and its repair. In figure A, in the upper left, 1-day-old infarct showing coagulative necrosis and wave fibers compared with the adjacent normal fibers on the right. Necrotic cells are separated by edema fluid. In figure B, in the upper right, there is dense neutrophilic infiltrate in the area of 2 to 3-day-old infarct. Later on, from 7 to 10 days, as seen in figure C, there is nearly complete removal of necrotic myocytes by phagocytic macrophages. In figure D, granulation tissue characterized by loose connective tissue and abundant capillaries. Figure E shows the healed myocardial infarct consisting of a dense collagenous scar. Here is the list of suggested reading. Hopefully you will find it useful for you. Thank you.